There are a variety of disorders that can have respiratory implications. In general, those disorders can be classified as obstructive, where somehow flow through the bronchial tree is affected, restrictive, where somehow the overall capacity of the lungs is reduced, or central, where there is a respiratory problem caused by a neurological dysfunction. Distinct symptoms associated with respiratory disorders includes dyspnea, discomfort in breathing, such as shortness of breath, excessive effort to breathe, and or tightness in the chest, and stridor, which is an audible sound during inspiration or expiration. Clinical management of respiratory disorders generally starts with assessment, such as pulmonary function testing for both speech and non-speech abilities. After evaluating any respiratory difficulties, a treatment is designed, and treatment places priority on different aspects of respiration for speech. The highest priority is to have a pressure that's appropriate to make normal sounding speech. The next priority would be to have a volume so that you can produce a normal quantity of speech. And then, last but not least, would be appropriate balance in the use of the chest wall and the abdominal cavity, which affects the fluency of speech and the ability to make fine adjustments in respiration. Treatment activities for respiration may start with working on respiration on its own, such as using a spirometer to look at airflow during breathing, but then we might then do that with phonation happening or with speech happening to evaluate volumes and flows in different contexts that become increasingly more challenging. Neurological disorders that affect respiration include Parkinson's disease, where there is general body-wide rigidity in the muscles that affects their ability to move. In the case of speech, you can get monotone speech, distortion of some phoneme sounds, a breathy sounding voice, and weak speech or speech with a low intensity. Generally, people with Parkinson's disease show reduced functional lung volumes, such as vital capacity or inspiratory capacity, even if they are being treated with medication. Inability to move the chest wall effectively increases the role of abdominal muscles in speech. A speech-language pathologist working with someone with Parkinson's on their respiration can practice increasing the effort they use for respiration in order to raise the intensity of their speech. Problems in the cerebellum can result in respiratory issues with speech. The cerebellum is crucial for coordination of all bodily movements. Someone with cerebellar disease may have unpredictable fluctuations in the loudness and pitch of their speech. They may compensate by producing speech in a slower, more monotone way with excess stress on individual syllables. Respiratory disorders affected by cerebellar damage influence things like vital capacity, likely because of the inability to coordinate all the different respiratory muscles for effective inspiration and expiration. A cervical spinal cord injury can result in nerve damage in the respiratory muscles that leads to weakness called paresis, or a paralysis and inability to move. This results in reduced loudness, imprecise production of consonants, the use of short breath groups in speech, so breaking speech up into more short phrases, a longer than normal inspiration phase in the respiratory cycle, and dyspnea, that effortful respiration. They will also show reduced vital capacity. Speech-language pathologists could work with a person with this problem by training them to increase their inspiration before they start speech so that they have adequate breath support for the speech they want to produce. Cerebral palsy can lead to weakness, involuntary movements, and lack of coordination of muscles. So a speech pathologist working with someone with cerebral palsy may try training their respiratory process in order to strengthen muscles, so having them take large breaths for vital capacity. And in addition, posture can be affected by cerebral palsy, which has an impact on the space in the thoracic cavity. Someone on mechanical ventilation, having artificial respiration take place, has particular difficulties with speech. With mechanical ventilation, machine is hooked up to the trachea to pump air down into the lungs and pull air back out. So a person under ventilation has a lack of control of their respiratory cycle. Generally speaking, that respiration is at a larger tidal volume than quiet breathing, but not as much as typically required for speech, and the pressures involved are greater than that used in speech. Therapy intervention involves training people to use speech in coincidence with the expiration cycle of the mechanical ventilation, continuing their speech until they no longer have that expiratory amount. There is a prosthetic intervention that's used in a variety of phonatory problems where you can put a speaking valve that routes air through the larynx, similar to something that would be used in a case of laryngectomy where an artificial larynx would be installed in the neck. People with voice disorders can have comorbid respiratory issues. If you have nodules or polyps on the larynx, you have inefficient airflow during phonation, as a lot of the airflow energy gets wasted in aspiration. This provides challenges to speech breathing. A larger inspiration phase is needed, and the expiration phase is extended to make up for the lost airflow, so additional muscular effort is involved. Higher than normal pressures are needed to make phonation happen. That extra muscular effort may also have an effect on the larynx itself with a strain or irritation developed during vocal abuse. It's difficult to adjust loudness based on lung volume. Having to make up for larynx inefficiency, again, can lead to strain and vocal abuse to make appropriate loudness adjustments. So a therapy intervention would involve training an overt control of inspiration and a better attempt to coordinate respiration with phonation. In the case of a physical issue with the larynx, that would probably be resolved surgically. Stuttering is a difficulty generally in starting sentences or words that leads to repeating words or parts of words, prolongations of individual sounds, silent periods in speech, excessive use of habitual fillers like and increased muscular tension during speech production. Some of the issue with stuttering seems to be coordinating all the different muscle activities that are required. So in the production of speech, you have to coordinate your respiration with phonation and articulation, including coordinating both the thoracic and the abdominal muscles, control of the inspiration and expiration onsets and offsets. Stutterers tend to start with speech at a lower volume and tend to extend respiration further past the resting state. They have difficulty timing phonation with the pressure generated from expiration, and overall have reduced pressure generation. So therapy intervention involving respiration would involve training overt control of respiration and focusing on diaphragmatic breathing to provide extra air capacity for respiration. Asthma is a narrowing of the bronchial tree due to an inflammation, swelling, or contraction of bronchial smooth muscles that are part of that incomplete ring with muscle connecting the open side of the ring. Typically, there's presence of dyspnea, stridor, and an excess use of thoracic as opposed to abdominal breathing. People with asthma may mouth breathe during quiet breathing, which makes breathing less quiet and reflects an increased attempt to improve airflow. You can diagnose asthma with pulmonary function testing. There's generally a reduced forced expiratory volume. The first second of expiratory volume generally reflects the larger airways like the trachea and the primary bronchi, the later parts of the forced expiratory volume reflect the function of the small airways, so that can give you a little more information about where exactly the inflammation is taking place. Asthma is treated primarily medically, but compensation strategies from respiratory issues with asthma during speech may lead to other speech and voice disorders or cases of vocal abuse. Paradoxical vocal fold motion is an inappropriate closure of the vocal folds and adduction that takes place during the inspiration phase of breathing. This results in the presence of stridor on inspiration and dyspnea. Commonly, paradoxical vocal fold function is accompanied by asthma and is therefore difficult to diagnose. One aspect of pulmonary function testing would reflect paradoxical vocal fold motion, and that would be a reduced forced inspiratory volume in comparison to a regularly normal expiratory volume. So this could be seen in a flow loop with a flattening of the inspiratory phase of the loop. Therapeutic intervention focuses on retraining respiration, overall relaxation of the respiratory and phonation muscles to attempt to head off that vocal fold adduction, and overall vocal hygiene, which is the care of the vocal folds, using appropriate breath support for phonation, being adequately hydrated, avoiding dehydrating drinks like caffeine and alcohol. In summary, a variety of disorders that affect respiratory function are treated in speech-language pathology, usually by having a more conscientious focus on the person's respiration. In other words, taking this autonomic neural function and making it somatic, making it something that we're consciously aware of and have more conscious control of. A priority in treatment is to first make sure there's appropriate pressure for normal sounding speech, then try to improve volume to be able to produce a normal amount of speech, and then finally working on differential use of the thorax and abdominal muscles in order to have fine control of respiration for speech. After this retraining, hopefully the client can eventually return to this new pattern of speaking as an automatic unconscious pattern of respiration.